Next, we'll invite Dr. Mary Q, who's at the Cleveland Clinic, the Cole Eye Institute. She's a glaucoma consultant there and Associate Program Director for the Glaucoma Fellowship. Welcome.
Popular. You're going to be a really popular glaucoma surgeon in your community if you keep in mind these tips and tricks for how to take apart the eye and put it back together again when doing tube shunt surgery. That's Carla Siegfried as Alphaba. These are my financial disclosures. They're not pertinent to this talk. In the spirit of the Oscars happening this weekend, I'm going to show you a series of short films featuring these steps in tube shunt surgery. And the nominees for how to open the conjunctiva are, here's a video from Michael Boland. He opens at the limbus and goes left and right and disinserts the tenons from the middle going outwards and makes a relaxing incision on each side, a relatively small one. Here's Mike Lynn from Mass Eye. He opens at the limbus, starts on one side and moves his way towards the other, disinserting the tenons from one side to the other. And he actually makes a small relaxing incision on the temporal side, not the superior side, which is not shown here. Minji Kang from Northwestern, she starts with the radial relaxing incision and then balloons up the conjunctiva with a liquid to help with the dissection. And then she marches from one side to the other and can disinsert the tenons from behind and makes a moderate-sized relaxing incision on either side. And here's me. This is a relaxing incision first, some liquid to balloon up the conj, marching across the limbus and disinserting the tenons with big snips, getting behind the tenons insertion with the tines of the scissors, and some really large relaxing incisions for a Barvelt. This is Ong Lee from Cleveland Clinic, and she's demonstrating a technique to open more posteriorly with a circumferential incision to get easier access to the back of the eye. Let's go through some examples of how to cover the tube. Here's Minji Kang doing a corneal patch graft with some interrupted, buried atovicryl on a BV needle interrupted knots. Mike Lynn, corneal patch graft, 7-ovicryl, unburied knot, and only anchoring it on one side and not the other because the conj closure keeps the patch graft in place. Here's me, scleral patch graft, 2 7-ovicryls, interrupted, not buried knot. I just mark it for the resident so they know where to go. Ong Lee, with her posterior opening, this is also a scleral patch graft, 2 interrupted vicryls, unburied knots. And here's Michael Boland showing a technique that you can use if you're operating at an ASC that doesn't allow patch grafts or something, and you can actually create a partial thickness scleral flap the way you would a trab, but here it is kind of turned 90 degrees, and you can use this to cover your tube. So you make the flap, put your tube down, insert the tube in the eye under the flap, and then close the flap on top of the tube with the same types of sutures you would use for a trab flap, and then rotate the knots and bury them. Here's a little bonus content. This is a pericardial tutoplast, which you can use if you have a very large area to cover. So in this video I'm about to show, there's an area of protruding uvea next to the new tube, and so this humongous pericardial patch graft can cover up both the tube entry site and the area of protruding uvea. A little more bonus content with capsule autografts. The next example is from my mentor, John Isengart, demonstrating the repair of an eroded tube using a capsule autograft harvested from the tube plate. Incise the capsule, cut off a piece, cut it into shape, and tuck it under the conj over the tube, and that's where the erosion was. Here's an example from me. This is a Barvelt 250 to 350, same quadrant exchange. The 250 was on top of the muscle. So I'm opening the capsule, cutting the anchoring stalks, removing the old tube, cutting off the entire anterior aspect of the capsule, and using that as a patch graft once I've done my tube exchange. The next example is also from me. It's a 350 to 350 exchange infranasally for an erosion. When harvesting the capsule from a 350, make sure not to go under the muscle, only take the part of the capsule that's between the 2 rectus muscles, and there will be 2 anchoring stalks here in this middle section. Harvested the patch graft and put it down. Here's a photo montage of most of the eyes that I did at my previous job at University of Chicago using a capsule autograft for a variety of tube exchanges and revisions and removals. We're going to publish this soon. And finally, let's go through some examples of how to close the conjunctiva. Michael Boland's method. There's a horizontal mattress at the limbus with a vicryl, and this prevents conj retraction. He closes the two wings with an interrupted vicryl with a spatulated needle, and he buries these knots. Then he closes the two relaxing incisions with interrupteds. Here's Minji Kang. She doesn't do the horizontal mattress in the middle. She closes the two corners with wings and then runs that back. And this is an atovicryl on a BV needle. And by anchoring both wings securely, there's no leak at the limbus. This is me. I hoist the tenons back up to the limbus to really take any tension off of that. So I drag on the tenons, not the conj. And I'm using chromic, which I learned from my mentor, John Isengart, which dissolves a little bit faster than vicryl and is a little more comfortable for the patient. I anchor the wings with interrupteds, and I do interrupteds along the relaxings. I don't run it back. I also do a traction suture in the sclera instead of the limbus, as shown there. Here's Mike Lin. He only has one relaxing incision, so he pulls the one corner of the conj up and tacks it down, and then runs that one relaxing incision back. This is the fastest opening and closure technique. And here's Ong Lee closing the posterior incision with 2 layers. This is an interrupted, closing just the tenons layer to take the tension off the conj. And then she closes the conj with a few interrupted, or you can also run this. A little bonus content for a tenons transposition. I want to make the point that you can move tenons around separately from conjunctiva by separating the conj from the tenons. And if you just need to cover something in a clock hour that's different than where you have tissue, separate the conj from the tenons, make a relaxing incision in the tenons away from where you need to be, and then drag the tenons to where you want to be, and then you can put the tenons down. In some cases, you can leave the tenons uncovered by conj as long as there's not a bleb under there. Some more bonus content featuring a conjunctival autograft, which can be taken from the same or fellow eye. The next example is a conj autograft from the same eye. Here's that tube erosion case, infranasal Barvelt 350. I've exchanged it for a new one, capsule autograft, but the conj is not going to close. So I took some conj from the supranasal quadrant of the same eye and dragged it down to the infranasal quadrant and put it there. Here it is 3 years later. The next video is a conj autograft from the other eye that was NLP, and this is a tube exchange in an eye with aniridia and limbal stem cell deficiency. Once I exchanged the tube, there was no way that was going to get back to the limbus. Here's the NLP other eye with a K-Pro, and I've delineated where the conj autograft is going to be. I balloon the conj with some liquid. This is similar to a pterygium surgery where you would harvest a conj autograft. And once it's free, I just move it to the first eye, suture it down, and here's how it looks a few weeks later. So there's no place like home, so let's review some take-home points. You should know how to open the conj at the limbus and posteriorly. It can be helpful to inject some kind of liquid to balloon the conj to help with the peritomy. The tenons might be easier to disinsert if you start with a radial relaxing incision instead of starting at the limbus. The posterior circumferential opening can be useful if the anterior conj is very ischemic or friable. Sclera and corneal patch grafts are common. Use cornea for inferior tubes for cosmesis. Use a pericardial pseudoplast if you need to cover a very large area. The knots securing the patch graft can be buried to reduce the risk of erosion. Capsule autografts can be harvested and used in the cases of tube revisions and exchanges. Tenons can be separated separately from conj and moved independently from the conj. The tenons does not have to be covered by conj, depending on what's underneath. Conjunctiva should be reapproximated without tension, but does not have to be closed with a continuous running suture. A central mattress at the limbus can reduce risk of conj retraction. When there's tension, close with vicryl. If there's no tension, consider chromic. It's softer and dissolves a little faster. The relaxing incisions can be closed with interrupted or running sutures. The interrupteds take a little longer to do, but kind of fall off as comfortable small knots instead of one long raveled suture. When opening and closing posteriorly, close the tenons and conj as 2 separate layers to take tension off that closure to reduce the risk of dehiscence. The knots in the conj closure can be buried to improve patient comfort, and conjunctival free grafts can be taken from the same or fellow eye as needed. I want to thank the Academy, the AGS Program Committee, for inviting me to give this presentation. Thank you to my mentors, Michael Boland and Jonathan Isengart, for my residency and fellowship, for teaching me a lot of these techniques and encouraging me to develop more techniques of my own. Thank you to my friends, Mike Lin, Minji Kang, and Ong Lee, for sharing some of their videos so that I could present them to you today. And thank you so much to my former trainees at the University of Chicago who taught me how to be a teacher, and my new trainees at Cleveland Clinic for allowing me the privilege to teach you all how to do glaucoma surgery, including tube shunts. This is how you can get in touch with me. The QR code is to my YouTube channel, which has more videos.